Our subject today is female urinary incontinence. What I mean by urinary incontinence in female? Urinary incontinence means involuntary control of micturition. The female cannot control her micturition, or it can be defined as the involuntary loss of urine, which form a social or hygienic problem to the female. And this leakage should be demonstrable, and you should see this leakage from the external urethral meatus. To understand the subject, you should understand the physiology of micturition and how micturition occurs in normal subject. And the normal subject should be continent during rest and during stress. And this will be explained in the next video to explain the physiology of micturition during rest and during stress, and how leakage occur in patients with stress urinary incontinence. Our subject today is urinary incontinence, female urinary incontinence. Urinary incontinence means inability to control micturition. Normal subject should be continent during rest and during stress. To understand the subject, you should understand the physiology of micturition, how micturition occurs. Imagine this is the bladder and this is the bladder neck. These are the ureters opening in the bladder, and the urine dribbles in the bladder from the ureter. Collection of urine in the bladder will cause stretch of the bladder and stimulation of certain receptors in the bladder mucosa. We call it stretch receptor. When this stretch receptor is stimulated, it sends impulses to the spinal center of micturition in the spinal cord. And this spinal center of micturition will send impulses to the brain, to the cerebral center of micturition. When this brain center of micturition is stimulated, it evaluates the condition. Is it suitable to evacuate the bladder, or the conditions are not suitable to evacuate the bladder? If the condition is not suitable, you are sitting in your home and you're driving your car, walking in the street, you tend to delay the desire of micturition. So the brain center will send inhibitory impulses to the bladder to allow more distension and the collection of more urine in the bladder. With more collection of urine in the bladder, this stretch receptor is stimulated again and again till the condition becomes suitable for micturition, and you can go to the WC. The brain center will send impulses to stimulate bladder contraction and evacuation of the bladder. This is how micturition occurs. To be continent, the pressure inside the urethra should be higher than the vesical pressure. As long as the urethral pressure is higher than the vesical pressure, the person is continent. When the urethral pressure becomes lower than the vesical pressure, incontinence occurs. We measure the pressure in the lower urinary tract by centimeter of water, not by millimeter mercury like the blood pressure. What happens during stress? For example, the bladder and bladder neck are situated inside the area of the abdominal cavity. This is the normal position of the bladder and the normal position of the bladder neck. And this position is maintained by the pelvic ligament and pelvic fascia. Suppose the pressure in the bladder is, for example, 8 centimeters of water, and the pressure at the bladder neck is 20. The pressure in the urethra is higher than the vesical pressure, and the person is continent, at rest. During stress, and what I mean by stress is any condition associated with increased intra-abdominal pressure during coughing, exercise, lifting heavy object, walking in the street. During the cough, for example, the intra-abdominal pressure is increased by a magnitude reaching up to 60 centimeters of water. This is the rise in the abdominal pressure during coughing. This rise is transmitted to the bladder, and the pressure becomes 68. And is also transmitted to the bladder neck, and the pressure becomes 80. So even during stress, the urethral pressure still higher than the vesical pressure. And this explains the continence during rest and during stress. What happens in patients with genital prolapse due to weakness in the pelvic support and the pelvic ligament? If this is the abdominal cavity, the bladder and the bladder neck descend from its normal position to an area outside the abdominal cavity. This is the bladder neck outside the abdominal cavity, and the bladder is still inside the abdominal cavity. We mentioned that the bladder pressure is 8 centimeters of water during rest, and the urethral pressure is 20. This is during rest. During coughing, the intra-abdominal pressure rises to 60 centimeters of water, but this pressure is transmitted to the bladder and not transmitted to the bladder neck. So the vesical pressure becomes 68, and the urethral pressure is maintained at 20. So the vesical pressure exceeds the urethral pressure, and the incontinence occurs during rest. This is how to explain the stress incontinence in patients with genital prolapse. What is the pathophysiology in patients with urge incontinence? You should know the difference. In patients with stress incontinence, the problem is in the bladder neck. But in patients with urge incontinence, the problem is with the stretch receptor, which is present in the bladder mucosa. This receptor is sensitized and hypersensitive to the collection of urine, and any amount of urine can stimulate this receptor and send the impulses to the spinal and to the cerebral center. This is the difference. The problem in the receptor and the problem in stress incontinence is in the bladder neck. We shift now to the causes of and the types of urinary incontinence. What about the causes and types of urinary incontinence? The most common types of urinary incontinence is stress urinary incontinence. This is the first type and commonest type, especially in patients with genital prolapse. You know the close relation between the urinary bladder and the vagina, and how the patient with genital prolapse, one of the main symptoms in patients with genital prolapse is urinary symptom, including stress urinary incontinence. What do you mean by stress? What I mean by stress? Stress in any condition associated with increased intra-abdominal pressure, like coughing, sneezing, lifting heavy object, bearing down, muscular exercise. The normal subject should be continent during rest and during stress. Leakage of urine during period of increased intra-abdominal pressure is known as stress urinary incontinence. And this is one step in gynecological examination. You should expose the external urethral meatus and ask the patient to cough to observe the leakage of urine from the external urethral meatus. Second type of stress incontinence is what we call urge incontinence. What I mean by urge? What do you mean by urge? Urge means strong, irresistible desire for micturition. Once the patient feels a desire for micturition, she can't stop this desire and she had to go to the WC to evacuate her bladder immediately. If there is any delay, the patient can't hold herself and the urine occur. You should know the difference between urgency and the urgency incontinence. Urgency means the desire for micturition and the patient can reach the WC without leakage. But if there is leakage in her way to the WC, this is what we call urge incontinence. There is different name for this condition. For example, urge incontinence, bladder instability, overactive bladder. These are the same terminology for the same condition. Third type of incontinence is the mixed type. The patient can complain of stress incontinence associated with urge incontinence, and this can occur in about 4 to 30% of cases. Next type is retention with overflow due to some neurological disease affecting the bladder. When the bladder is distended, even reaching to the level of the umbilicus, so any amount of urine dribbling from the ureter go out from the urethra, and this is the retention with overflow. Other type of incontinence is functional incontinence in patients who are not able to void for long-standing immobility after, for example, surgical operation. Next type, which is the important type, is the traumatic fistula or genitourinary fistula following surgery or difficult delivery or following hysterectomy, abdominal hysterectomy, or vaginal surgery. There is communication between the bladder and the vagina, or communication between the ureter and the vagina. This is the traumatic fistula. Urethral diverticulum and congenital anomalies, for example, ectopic ureter or ectopia vasica. This is another type of incontinence. Other types of incontinence, like temporary incontinence in cases of urinary tract infection or atrophic urethritis, or in patient taking antidepressant drug, or in cases of fetal impaction. What is stress urinary incontinence? Stress urinary incontinence is the involuntary loss of urine when the intravesical pressure exceeds the maximal urethral closure pressure. When the vesical pressure exceeds the urethral closure pressure. But the important thing is the absence of detrusal activity or absence of overactive bladder. Genuine stress incontinence is not a clinical diagnosis. You can't say this patient is complaining of genuine stress incontinence after clinical examination. You should do urodynamic investigation before saying that this patient is complaining of genuine stress incontinence. So it is a urodynamic diagnosis. What about the pathophysiology of stress incontinence? There are two main types of stress urinary incontinence. The commonest type is the stress urinary incontinence when the bladder and the bladder neck is displaced from its normal position to a lower position due to weakness of the pelvic ligament and the pelvic support. This is the main type, and that's why I explained in the previous video that during stress, the abdominal pressure is not transmitted to the bladder neck, but is transmitted totally to the bladder in patient with displacement of the bladder neck, in patient with genital prolapse. So the failure of transmission of the abdominal pressure to the bladder neck is the main etiology of stress urinary incontinence in patient with genital prolapse. And this patient is exposed to this pathology or pathophysiology following the menopause, which cause failure and atrophy and the lack of strength of the pelvic support and pelvic ligament. So menopause is a cause. Traumatic delivery or badly managed labor is the second cause for stress urinary incontinence, or the second cause of weakness of the pelvic ligament and the pelvic support. The third cause is a congenital form of weakness, which can cause generalized weakness in body ligament in general. So any patient complaining of weakness of support and descent of the bladder neck, this is the first type of stress urinary incontinence. There is another type of stress urinary incontinence which we call it intrinsic sphincter deficiency. There is intrinsic deficiency in the tone of the urethra. And in this patient, the bladder and the bladder neck are in its normal position in the pelvis. There is no weakness in the pelvic support, but there is weakness in the tone of the bladder and tone of the bladder neck. This is the second type of stress urinary incontinence. We call it intrinsic sphincter deficiency. This is a traumatic delivery, which causes denervation of the pelvic floor muscle and the sphincteric muscle. Also, previous pelvic surgery and aging can cause weakness in the pelvic support. Also, obesity and menopause are another causes. What about the incidence of genuine stress incontinence? It ranges from 24% to 52%. There is a wide range of incidence because stress urinary incontinence, if it is mild, it cannot cause hygienic or social problem. It causes social and hygienic problem when it is when there is marked leakage of urine. Minimal leakage of urine is considered by some women as a normal event, and this is the cause of the variation in the incidence of stress incontinence. How to diagnose stress urinary incontinence or genuine stress incontinence? The gold standard for diagnosis is seeing urine leaking from the external urethral meatus during vaginal examination or during, it is one step in vulval inspection, is to expose the vestibule and expose the external urethral meatus and ask the patient to cough and observe the leakage of urine from the external urethral meatus. This is the gold standard for diagnosis, and we call it stress test for diagnosis of urinary incontinence. How to investigate a patient with urinary incontinence? You can do frequency volume chart. You give a chart to the patient and ask the patient to record the frequency of micturition and the volume of urine voided and the number of leakage in this chart. And this is very important during examination. Second step is urine analysis to exclude urinary tract infection. You can do cystoscopy, you can do plain X-ray to exclude the presence of any stone in the bladder or any foreign body in the bladder, which can irritate the bladder mucosa. We shift to the second cause of urinary incontinence, which is urgency incontinence. By urgency incontinence, the patient, once she feels a desire, she have strong desire to evacuate the bladder, and she have to go to the WC to evacuate the bladder immediately. And as we explained in the previous video, the problem in cases of urgency incontinence is not in the bladder neck, it is in the bladder mucosa, because the stretch receptor in the bladder mucosa is irritated and hypersensitive. And the cause of this hypersensitivity is two main causes. First, urinary tract infection. Second is the outflow obstruction of urine, especially in female inpatient with genital prolapse, and the kinking of the urethra will cause obstruction to the flow of urine. And this problem is present also in male subject. For example, in patient with prostate, for example, it causes obstruction to the flow of urine, and many patients with prostatic enlargement complaining of urgency and the urgency incontinence. The problem in urgency incontinence is in the stretch receptor in the bladder mucosa and not in the bladder neck. I will ask a question. Can you differentiate between patient with stress urinary incontinence and urgency incontinence during history taking and the clinical examination? If you are taking a history from a patient with urinary incontinence and you are taking the present history, what question to be asked to differentiate if this patient is complaining of stress incontinence or urgency incontinence? First, the complaint of the patient is different. In patient with stress incontinence, the patient is complaining of leakage of urine during coughing, sneezing, for example. But the patient with urgency incontinence is complaining from this complaint. Once she feels the desire, there is a strong desire for micturition, and she has to go to the WC to evacuate the bladder. And if there is any delay, there is leakage of urine in her way to the WC. This is the difference in the complaint. The second difference is the presence of desire. In patient with stress incontinence, there is no desire for micturition. The patient leaks just with coughing. There is no desire for micturition. But in patient with urgency incontinence, there is a strong desire for micturition. The third difference is the amount of urine leaked. In patient with stress incontinence, there is minimal leakage of urine, just drops of urine during cough. But in patient with urgency incontinence, there is leakage of large amount of urine. The whole bladder is evacuating, secondary to strong contraction of the detrusor muscle after the patient feel the desire. The third difference or the fourth difference is for example, the frequency of micturition in patient with urgency incontinence. There is frequency of micturition, and this is not present in patient with stress incontinence. There is a special investigation to differentiate between stress incontinence and urge incontinence. This important investigation is what we call urodynamic investigation, because the lower urinary tract is not static. The lower urinary tract is in a dynamic process. The bladder distend and contract, distend during filling and contract during voiding. The urethra close the bladder neck during rest and open the bladder neck during voiding. This is a dynamic process. So we call this investigation urodynamic investigation. The aim of this urodynamic investigation is to measure the pressure changes in the bladder and the urethra during voiding and during filling of the bladder. There is many urodynamic investigation. As you see, you should evaluate the residual urine estimation after micturition, the amount of urine remaining in the bladder after voiding. This is what we call residual urine volume estimation, and this can be estimated by catheterization of the patient after voiding or by ultrasound. You can measure the volume of urine remaining of the bladder after evacuation. The second investigation is what we call filling cystometry, or measuring the pressure changes in the bladder during filling of the bladder. This is filling cystometry, and this is very important investigation to differentiate between stress incontinence and the urgency incontinence. Another test is voiding cystometry, is measuring the pressure changes during voiding. There is ambulatory urodynamic. There is urethral pressure profile, which is measuring the pressure in the urethra during filling of the bladder and during voiding of the bladder. This is different type of urodynamic investigation. The most important investigation to differentiate urge incontinence from stress incontinence is doing filling cystometry. Filling cystometry measures the pressure during filling of the bladder, and the patient feel the first sensation or the first desire to micturate during filling cystometry. We call it first sensation at about 100 ml or 150 milliliter of urine. During filling of the bladder or during filling cystometry, once the patient feels a desire to micturate, you should ask her to hold herself, or what we call inhibit this desire of micturition, or inhibit the contraction of the detrusor. If the patient can inhibit this desire and continue filling the bladder, this is the normal. And if she can't inhibit this detrusal contraction during filling cystometry, this is the abnormal. So the presence of uninhibited detrusal contraction is diagnostic for urgency incontinence. And if you are in doubt after taking history from the patient, whether this patient is complaining of stress incontinence or urge incontinence, just ask for filling cystometry, which is a urodynamic investigation. And when you examine the trace of filling cystometry, if you find uninhibited detrusal contraction, this is diagnostic for urgency incontinence. If there is no uninhibited detrusal contraction, it is diagnostic for stress incontinence, and you can confirm your diagnosis by doing urethral pressure profile. If the urethral pressure is less than 25 or 20, this is diagnostic for intrinsic sphincter deficiency. What about the management of stress incontinence and the urgency incontinence? You can do conservative management, especially in mild cases, especially for if there is mild incontinence in postmenopausal women during pregnancy, during postpartum period, or the patient is refusing surgery, or the patient is unfit for surgery, or mild occasional incontinence. This is the indication of conservative management. This is first line of conservative management is the physiotherapy by pelvic floor exercise, what we call Kegel exercise. Ask the patient to hold your finger in the vagina during vaginal examination and ask the patient to hold your finger. This is the Kegel exercise. And ask the patient to repeat this several times in the morning and in the afternoon and at night. For example, start by 10 contractions, then increase it to 20 contractions, then 30 contractions. This will cause rehabilitation of the pelvic floor, and the pelvic floor muscle become more stronger, and mild incontinence can be treated by pelvic floor exercise. Second line of treatment is by drug. For example, estrogen replacement therapy in postmenopausal women. You know, after the menopause, there is atrophy of the pelvic ligament, and estrogen may reinforce the pelvic ligament and pelvic fascia, and the patient can improve with hormonal replacement therapy. Anticholinergic drug, especially in patients with urgency incontinence. This anticholinergic drug causes relaxation of the detrusal muscle and allow more distension of the detrusal muscle to allow more feeling. I want to concentrate in one important point. In patients with stress incontinence, the main line of treatment is surgical treatment. In both types of stress incontinence, whether there is descent of the bladder neck in patient with general prolapse or there is intrinsic sphincter deficiency, the main line of treatment in patient with stress urinary incontinence is surgical treatment. You have to reposition we have to make reposition of the bladder and the bladder neck in its normal position. If the bladder neck descends due to weakness of pelvic ligament, you have to replace the bladder again in its normal position and support it by the pelvic fascia and the pelvic ligament to prevent redescent of the bladder. This is a surgical line of treatment. Also in patients with intrinsic sphincter deficiency, you can apply a sling, what we call sling operation, like TVT or transobturator tape, to evaluate the bladder neck and to evaluate the bladder, the mid-urethra, and this tape is attached to the rectus muscle. And so when during coughing or sneezing, this sling will elevate the bladder neck and the mid-urethra and close it during stress. One important point is the main line of treatment is surgical treatment. What is the case in urgency? In urgency, there is no descent. The main problem is in the stretch receptor, which is hypersensitive to any stimulation. And the main causes of this hypersensitivity is urinary tract infection and outflow obstruction. So the main line of treatment in urgency incontinence is medical treatment. You have to do urinary tract and urine analysis and culture sensitivity if there is urinary tract infection, and give the patient the appropriate antibiotic, and you can give with this antibiotic anticholinergic drug. This anticholinergic drug will cause relaxation of the detrusal muscle and allow more feeling and more distension of the bladder. So you should manage genital prolapse by vaginal procedure like anterior colporrhaphy or vaginal hysterectomy and the repair of the pelvic floor. There is many operations for treatment of stress incontinence, more than 150 operations for the treatment of stress urinary incontinence.